Thank you, Ruben, for the short introduction. So it's a pleasure for me to introduce and moderate this session presented by Dr. Popa. She's a cardiologist and a cardiac electrophysiologist with a keen eye for fundamental research. But this is not what we will talk about today. She will present her newest paper. You can see the title, Safety Profile, Long-Term Efficacy of Very High Power Short Duration Catheter Ablation for Atrial Fibrillation. Some of you might be familiar with the term high power short duration. It involves a specific energy setting to obtain efficient results, especially in the atrial walls, without compromising too much the safety of the adjacent structures. Miruna is a cardiologist from Munich, from the team of Isabel Deisenhofer, which is also a collaborator of the Institute. And she has performed, this paper is accepted in Europace. Is that Miruna? Is that correct? Yes. It's accepted in Europace, is not yet available online, but you will see it focus on the classic features of a retrospective study involving ablation for atrial fibrillation. So that being said, I leave the stage to Miruna, please.
Okay, thank you, Guido, for the nice introduction. I hope everyone can hear me now. I unmuted my microphone. So thank you for inviting me to present this journal club. I arrived here at Lyric 1 month ago, and I was able on my very first day to attend the last journal club of Guido. And well, I'm very happy to share with you this data. It's, as Guido already told you, it's clinical data, so I hope that is still interesting for you. Please, if you have any questions or remarks, please be free to ask. So my paper is on very high power short duration, and I think it's also interesting to show this because the settings we used in our clinical setting are based on, or were actually initially validated here at Lyric by a colleague of mine who also came here as a clinical fellow. So I think this also shows a nice history of how the data were validated here in vitro and what are our first long-term results now in patients. So I will move to the next slide. If I see. Okay, great. So to the background, I think we all know the meaning of pulmonary vein isolation and that it represents a cornerstone of atrial fibrillation ablation, and the radiofrequency energy remains one of the main modalities used nowadays for performing pulmonary vein isolation. When we do a PVI, what are we aiming at in terms of lesions? We're aiming at transmural, irreversible, and contiguous lesion on the one hand. On the other hand, we want to avoid collateral tissue damage as much as possible. So the aim of PVI, and when using catheter technologies in this case, is to maximize efficacy while also maximizing safety. And despite, in the last 20 years, there were a lot of technological advances concerning radiofrequency ablation. We have now open irrigated tip catheters. We have live monitoring of temperature and catheter stability. We have contact force catheter. However, PVI still has some limitations, such as acute and chronic pulmonary vein reconnections, which remain a main reason for clinical recurrences. On the other hand, there are still, even if the safety has greatly improved in the last 10 years, we still see complications related to extracardiac tissue damage, such as pericardial tamponade or esophageal lesions. So conventional or the traditional way of applying the RF ablation in the clinical setting has been 20 to 40 watts applied for 20 to 30 seconds in a power controlled mode. This is the standard ablation and the ablation settings. Around 5 years ago, there was an interesting there was an increasing interest in using so-called high power short duration ablation because first results in animal experiments and also ex vivo experiments had shown that it may be associated with a more favorable lesion geometry, which could eventually translate into better efficacy and safety in the clinical setting. So how is high power short duration defined? There is not a general definition for that, but there's a consensus that we define high power short duration as applying more than 45 watts for less than 20 seconds. However, as you will see in my presentation, the settings used in the clinical setting are still quite heterogeneous. So at this point, we have started having some data on clinical data on high power short duration. However, this data originated from small comparator studies, including 100 to 200 patients per group. However, the data on large cohorts is still lacking, and this is important when considering that the safety aspect, that complications nowadays such as tamponade or atrioesophageal fistula are way less than 1%. So in order to analyze the safety in a clinical setting, you need more patients. Also, data is limited using high power short duration above 50 watts. So this is the general the aim of our study was to analyze these 2 points. In order to explain to you why high power short duration or how high power short duration has emerged, I would like to describe a bit the biophysical characteristics when using radiofrequency energy to gain a thermal lesion. So usually when applying standard power, the lesion is generating during 2 phases of early resistive phase and a later conductive phase. During the early resistive phase, which is thought to occur in the around first 10 seconds of RF application, there is the tissue is heated above 50 degrees by direct influence of the electrical current at the tissue catheter interface, and this leads to immediate cell death. In the later part, the conductive heating, this pool of energy, so basically the thermal energy which accumulated during the resistive heating expands into other regions. And the issue with conductive heating is we don't really want that when doing our ablation lesions, because it may increase the risk of reversible lesions, so just creating tissue edema, which later can lead to pulmonary vein reconnections. And on the other hand, it may increase the tissue, so the lesion death by the effect of conductive heating may lead to how to say, transmitting the heat energy at deeper tissue levels, which could lead to extracardiac tissue damage. So when designing high power short duration, the idea was to create similar lesion volumes. However, the idea was to that the lesion would be generated during the resistive phase, so that we have this an irreversible lesion and less effect of the conductive heating. And first...
Can I ask a question? Does that mean that the lesion depth is less with the high power lesion, or?
Yes, the next slide will answer that question.
Okay.
So the answer is no. We actually expect a shallower lesion with high power short duration.
Okay.
What I wanted to show here first is there were linear lesions applied in an in vivo swine model. And as we can see here, with high power short duration, the authors saw less, basically no evidence of gaps compared to the standard ablation. And I would like to go now to this slide, where this is the work I talked about at the beginning. It was results which were generated by my colleague Felix Bourrier, who's also working in Munich with me. He came here some years ago as a clinical fellow, and together with a group here, he did an in silico analysis in order to find out which power and duration settings can be used and would expectedly generate the same lesion volume. So using this ablation index, which is an proprietary algorithm of Bassens-Webster, and which correlates well with lesion volume, they were able to show that, for example, when applying 70 watt for 7 seconds, it will generate, at least in the computer simulation, a similar volume as when ablated 30 watts, 30 seconds, so the conventional ablation. So to come back at your question, they were able to show that lesions had a similar volume when using those high power short duration settings. However, they saw that they were shallower. So the lesion had a smaller depth, had also a higher or a larger diameter, and the diameter was reached its highest point in the just under the endocardium, whereas the lesions with 30 watt 30 seconds had a more teardrop shaped, and the diameter was so they saw this phenomenon of endocardial sparing. So basically, when ablating in the atrial tissue, what we want are indeed shallow lesions, which are of course should remain transmural, and wide lesions in order to improve lesion to lesion contiguity. I hope this answers your question.
Yes, very good. Yeah, and the background, of course, is that the idea is that if you have contiguous lesions, you better protect against pulmonary vein foci, assuming that this is the mechanism of atrial fibrillation, of course, which is not necessarily true. But that's another question, maybe.
That is true, indeed. So what we want to perform is a pulmonary vein isolation, which is efficient and safe with reduced risk of gaps. And in theory, at least when we look at this ex vivo data, high power short duration seems to be ideal. The question is, of course, does this also translate to the clinical setting? And why I wanted to show you this slide was that also that basically when Felix Bourrier came back to us in Munich, we applied these settings in the clinical setting. So we applied 60 watts 10 seconds and 70 watts 7 seconds. This became more or less our clinical routine when ablating. So this is the background of this study. So coming back to our retrospective analysis, we included over 1,000 patients who received their first time AF catheter ablation. We included both patients with paroxysmal AF as well as patients with persistent AF. And they were ablated using circumferential PVI, point-by-point lesion, and some patients also received additional substrate modifications. So we included in this retrospective analysis the very high power short duration group, 574 consecutive patients. Basically all the patients, we started performing this kind of ablation in April 2018, and we included all patients starting from that date. And in order to have a comparator group, we included a historical cohort. So it was patients ablated up to 3 years earlier, also consecutive patients with standard ablation settings. What is important to say is that ablation workflow and the ablation catheters remained the same. So in our workflow, when implementing high power short duration, it was only the power set and duration settings which were different, but the rest remained actually the same. We used the same catheters. So we used 70 watts for 7 seconds with the flexibility catheter due to its enhanced irrigation tip. We chose to use 60 watt for 10 seconds, so a bit less power with the STSF catheter due to a previous report which had shown higher risk of steam pops when applying very, very high power short duration with the STSF catheter. So this is the background of our power settings. And then in this analysis, we performed follow-up. So we looked at the safety defined as complications in and out of hospital complications occurring within the first 30 days, and efficacy defined as freedom of any atrial arrhythmia of antiarrhythmic drugs as assessed with 5 to 7 day Holter ECGs. So I'll move on to the results. These are the baseline characteristics of our patients. We see that the characteristics were well balanced between groups, even if we did not perform any matching, because the data was, as I said, the characteristics were well balanced. The only difference was in the left ventricular ejection fraction. It was significantly more reduced in the high power short duration group. However, if we look at the numbers, I wouldn't expect that to be of clinical significance. I think it's more like a statistical significance. If we look at the procedural data, we see that additional substrate ablation was also well balanced between groups. So it was around 49% of patients received substrate ablation additional to PVI. The use of contact force catheters, so the STSF catheter, was virtually identical between groups. So this makes both groups, we think, quite well comparable. And when looking at procedure radiofrequency and fluoroscopy duration, we see the same trend, which also other reports have consistently reported, meaning a significant reduction in procedure and radiofrequency duration. We also saw a difference in fluoroscopy duration, even though other studies could not show this. If you look at complications, so the safety data, we also did not find a statistical difference between groups. The complication rates were low in both groups. We did not see any stroke or atrioesophageal fistula in those two groups. When looking at details of the major complications, so one was the cardiac tamponade. Interestingly, in the high power short duration group, the 2 tamponade cases which we had were not directly related to the use of high power short duration. So one was occurred immediately after the transeptal puncture before RF application, and the second tamponade occurred during a steam pop during ablation of the cavo-tricuspid isthmus. However, this was done with 40 watts because we continued using standard ablation for the line of the cavo-tricuspid isthmus line because of a thicker tissue where we want more lesion depth. And also for the anterior line, we also used conventional ablation. Further, how about the efficacy data? This are the Kaplan-Meier curves showing the freedom from atrial arrhythmia after a single ablation. This was both off antiarrhythmic drugs. And we saw that the 12-month freedom from atrial arrhythmia was significantly higher. However, this was only true in the persistent AF cohort. So there we saw a difference of 44.1% compared to 34.2%, so almost 10% difference. For paroxysmal AF, we also saw a trend towards high power short duration. However, the result was not statistically significant. So the next question which we asked was, is very high power short duration also independently associated with arrhythmia freedom? In order to analyze this, we first did univariate analysis, and we saw that in persistent AF, patients with recurrence had mean higher age, were more frequently female, had a lower left ventricular ejection fraction and a higher CHA2DS2-VAS score, whereas patients without recurrence had been ablated to a higher percentage with very high power short duration. When performing the multivariate analysis, it was indeed very high power short duration in the persistent AF group, which remained the only independent predictor, in this case, a negative predictor of arrhythmia recurrence. So it was protective for the occurrence of arrhythmia recurrence. For paroxysmal AF, the two independent predictors were female sex and vascular disease. So I think we're going to discuss this later. What I wanted to show on this slide is to summarize a bit the results. So basically, this study is the largest available study to this point, comparing the safety and long-term efficacy of very high power short duration in over 1,000 patients. And it shows that AF catheter ablation using very high power short duration is as safe as conventional ablation, that it is associated with a reduced procedure, RF, and fluoroscopy time. And it was also associated in our cohort with improved outcomes in persistent AF. Thus, results are in agreement with previous reports of smaller comparator studies. I brought this slide with me in order for you to better have a better overview of what has been published so far on high power short duration. And we see this is a review from last year and published in JCE, and we see that there is a trend for a higher AF freedom with high power short duration compared to the conventional ablation, and we also see a trend for high power short duration towards less complications. So what we also have to bear in mind when considering the current data is that this is a retrospective study with the inherent limitations of the study design. And we also have to bear in mind that comparisons of very high power short duration was performed with a historical conventional ablation cohort. So as you know, is comparisons with historical cohorts are sometimes difficult. What one also has to bear in mind is when applying high power short duration is that there is a narrow safety to efficacy window. So even when small changes in power and duration can compromise both efficacy and safety. So this is also an important issue when interpreting this data, is that ablation, the settings we used in our clinical settings, may not be applicable also to other catheter tip designs. Safety of high power short duration is also dependent on other variables such as baseline impedance, catheter stability, tissue characteristics, and operator experience, all factors which have not been systematically assessed in this study. So the question remains, how do we have any prospective data on silent cerebral and esophageal injury? I would like to show you some few slides. I have only 3 slides left on some preliminary data from our randomized control study. So we also performed a randomized control trial comparing very high power short duration with standard ablation. And I'd like to share these results with you. There was 150 patients which were randomized. And what we saw, this was all paroxysmal AF patients. What we saw is basically very similar, so a trend towards a better outcome, 1 year freedom from any atrial arrhythmia with high power short duration, however, without statistical significance. And we also, in the last 35 patients of this study, we also performed MRIs in order to find out if the patients had silent cerebral lesions. And we found out that patients in the standard power cohort had, so 23% of patients had silent cerebral lesions compared to 5% in the high power short duration. So the results were, of course, it's a very small number of patients, a sample size number. Results are not significant, but it gives at least an idea at what we're looking at. We were also able to show that catheter stability was improved with high power short duration. So the catheter movement at the beginning and at the end of the ablation application was significantly shorter when using high power short duration. I found this paper last week. It was just published in Europace last week, and I also wanted to show it to you because it's exactly what we were talking about, silent esophageal lesions, and it was also a randomized controlled study, and they found no difference in a silent esophageal lesion, high power short duration, and conventional ablation. However, this group used 40 watt for high power short duration. So as I already mentioned, the definitions are quite heterogeneous. So this leads us to the conclusion that catheter ablation using power controlled high power short duration appears to be as safe as conventional ablation based on the data we have so far. High power short duration is consistently associated with significant reduction in procedure duration and RF duration. And the first data shows that high power short duration ablation might also be more efficient than conventional ablation, especially in persistent AF. However, the settings employed and the catheter technologies employed are very heterogeneous. So the ideal combination of power, duration, and catheter tip design generating transmural lesions at lower risk of collateral tissue damage remains to be established. Thank you for your attention, and I'm looking forward to the discussion.
Thank you, Miruna, very much for this extensive presentation of your work and collateral works regarding high power short duration. It's pretty much remarkable looking at this data, how heterogeneous this field is with the same intent, and how difficult it is to compare different studies that revolve around this relatively new application of radiofrequency ablation for atrial fibrillation. And it's also important to stress again, as you said, that the ablation of the additional substrates needs the flexibility that is given by radiofrequency ablation when it comes to deciding how much energy you want to transfer to the tissue in order to create the lesion that you want. Something that, for example, is not yet available for other potentially more efficient forms of energy like pulse field ablation. I would like to, I have just a few comments. We have discussed this with Miruna many times. So I would like to leave the floor to you, the audience, for the questions. Please go ahead.
Yeah, I have a question. As I understand it, paroxysmal atrial fibrillation is primarily thought to occur as a result of focal origin of in the pulmonary veins, whereas persistent atrial fibrillation is more related to a substrate in the atrial body itself. Now, you show that there is a difference in efficacy in the types of atrial fibrillation. So it is more efficient in persistent atrial fibrillation than in paroxysmal atrial fibrillation. How do you explain that? I would have expected that it would be the other way around if your lesions are more contiguous.
Yes, thank you for the question. I was also asking myself the same question when analyzing the data. My opinion is that it's definitely patients with persistent AF have a more diseased atrium, have a larger atrium, have electrical and structural remodeling going on. And what would expect that pulmonary vein isolation would not address the real or at least all issues. What I think is that, we see some results with pulmonary vein isolation alone. What I think is that when using high power short duration in persistent AF patients, the issue of catheter stability, which is probably improved when using high power short duration, plays a better or a higher role. Because I think in persistent AF, it is of course only a theory, but I think in persistent AF we have those larger atria where it is also more, it might be more difficult to stabilize the catheter. So in this case, this advantage of using high power short duration, where in case you remember a slide I showed you, the mean catheter movement was reduced. This may partly explain why we saw better results with high power short duration. So maybe the PVI itself is better in when using very high power short duration in persistent AF, but still we only have 40% freedom of any atrial arrhythmia with one ablation. So there's still a lot more to do when performing therapy of persistent AF.
Yeah, thank you. Very good.
Anyone else?
Yep. Hello. Yeah, I have a quick question too. You said that the procedure duration is reduced with the high power short duration, and I think I saw roughly around 35 minutes. Is most of that reduction of the time because the duration of the ablation is only 15 to 20 milliseconds less, or is it because you have the shallower lesions and you have to use less ablation points? Or is it a combination of both? I'm not so sure.
Probably it is a combination of both. I cannot answer this question specifically for this retrospective analysis because we did not have all the data. Being a retrospective analysis, we did not have all the data with the pulmonary vein reconnections. So I think it's a combination of less RF energy per se and maybe less reconnections. But what I can answer is definitely is based on our prospective data from the paroxysmal AF, from the randomized controlled trial I showed you, we saw significantly less acute reconnections with very high power short duration. So it was also the, if you want, the number of lesions, which was significantly reduced.
Thank you.
Hello, if I may have a question.
Yes.
Maybe I missed, yeah, thanks for the talk. Maybe I missed the information at the introduction somewhere, but this is a retrospective study, right?
Yes.
And so as I understand it, so what was the indication for the high power short duration procedure, and what was the indication for the standard procedure then? Or was this somehow random, or how shall I interpret this fact that it's a retrospective study from the information? Yeah.
Yes, so the indication was basically the same. It was patients with symptomatic paroxysmal or persistent AF who were referred to our center for ablation. That was the indication in both cases. The difference was only the time when we performed the ablation. So we had a cutoff in 2018. Then we started performing very high partial duration in every patient. Basically, that's what how I already said. It's a comparison with the historical cohort. So between 2015 and 18, all consecutive patients receiving the standard procedure were compared to all consecutive, the next 3 years of consecutive patients receiving the standard procedure. I hope this answers the question.
Okay, I see. So basically, if yeah, I'll a little bit rephrase this just to know. So let's imagine that now someone would, or you would perform a prospective study. Would you assume the outcomes would be comparable, or you think there might be some differences compared to this study because this is a retrospective one?
So as I've shown you, we have meanwhile we have some quite robust data from our randomized control study, where we randomized patients 1-to-1 receiving either conventional ablation or high power short duration, and we see that the slide. Okay, you're still seeing the slides?
Yeah.
Mm-hmm.
Yes, I'm trying to go back, which is not easy. Huh. Vito, can you exit from presentation mode? Yeah. Okay. You still might see my screen?
Yeah.
Yes.
Okay. Yes, exactly. So these are the results of the randomized control study. And basically, we see more or less the same trend. We see a better outcome with high power short duration, and as also other small studies have shown. However, this fails to become statistically significant. And my theory is it's just a matter of sample size. If you want to have statistical significance of those 8% or 6%, we just need a larger sample size. And if we look at, now talking about paroxysmal AF, and if you look at the other slide, also the results of where we had 500 patients compared to 500 patients, we see that it was almost at the limit, almost statistically significant. So maybe we need 1,200 patients in order to achieve the significance. But in order to come back to your question, I think that our prospective data also shows very nicely that this data from the retrospective study, at least in our center, are reliable.
Great, thanks.
And the slides also show that the efficacy in paroxysmal AF is higher than in persistent AF, which makes sense, of course. But that, well, to be honest, the difference between the two modes of energy application is much less than the effect that you would like to see. You want to be at 100%, of course. And well, this is a general finding in all studies that our treatment of AF by ablation is simply not very effective yet. I think we need to find some new modalities. And this one may help, but it's a small advance. Although, yeah, very important, I would say. But maybe we should rethink our idea about the mechanisms of arrhythmia, of atrial fibrillation. That's what I try to refer to in what I first said. maybe we should forget about the idea that there is a focal origin of atrial fibrillation in paroxysmal AF, for instance. Although Michel Hessegaer will not like that idea.
And I am not expecting that. I have one question for you, Miruna, actually. One in particular. You mentioned in your prospective study that you have CMRI, but you talk about silent ischemias. So are those like cardiac MRIs or MRIs of the brain?
Sorry, those are cerebral.
Okay. Okay. So no, cardiac MRI gave me a lot of some images. Okay.
It was a translation from German, so that's why. Sorry.
That's okay. And yes, just this. Is there any other question from the audience? No? Okay. Well, I must say that Ruben, I completely agree with you. That is somehow depressing that all this work and really a lot of tries, a lot of ingenuity, a lot of adaptation of a very flexible form of thermal ablation is just not breaking the barrier of 80% in the long-term freedom from arrhythmia. And for persistent atrial fibrillation, it's just devastatingly depressing. I imagine for you clinicians even more than for me, that I see this just as a researcher. But it really pushes us to consider different ways to treat, if not cure, these patients from this condition. One thing that I noticed now, and Luna, maybe you can confirm this to me, your blanking period is 6 weeks, not 3 months.
Yes.
It's a choice based on from your center, because I know that you are also expert in early recurrence.
Yes, thank you for the question. Indeed.
For my previous work,
Oh, yeah, sorry.
Okay, now without a double voice. My previous work analyzed the predictive value of early recurrences of atrial arrhythmia occurring during the first 3 months, because current guidelines, or not only current guidelines, it is more or less a tradition to set a blanking period of 3 months, during which it is said that any recurrence occurring during that period doesn't have any prognostic significance. One should tell the patient to wait, that it will become better, and so on. But however, this is a great reason for frustration in the clinical setting. So we performed also a large analysis looking at these early recurrences, and we found out that they are highly predictive of later recurrences, and that extending the blanking period from 1 month to 3 months did not make any difference. And there is also accumulating data on that, and I think the direction will be that the guidelines might take this into consideration at some point, and that the blanking period will be reduced to at least 6 weeks, if not even 4 weeks. So that's why, since we have this robust data on the predictive value of this early recurrences, we applied this in our clinical routine, and we only use 4 to 6 weeks maximum blanking period.
Yeah, this fits nicely with the work of Lisa Gottlieb, who worked in the lab in Lyric, who exactly showed the same thing. In fact, the first week after the ablation shows increased post-surgery or post-operative AF. And after that, the arrhythmias did have predictive value for long-term efficacy. So I think we should forget the blanking period entirely. I mean, it's stupid not to look at the patient for 6 weeks or 3 months if you can acquire all kind of information for that from him or her.
Absolutely.
Yeah.
Yes. And what we also saw is that we performed this analysis separately, so for paroxysmal and persistent AF, and we saw that with especially for persistent AF, these were highly predictive. So this also is an indirect, for me, an indirect sign that we're looking at substrate. We're looking at substrate, or let's say untreated substrate,
Yeah.
by the ablation.
I agree.
With that said, by the way, thanks you again. I did not say on my last question, I think you did a very good job of clearly describing the data. That was very good. But my question now is, I saw when you came and talked about your meet and greet, you were doing some PFA, some pulse field ablation. So I imagine pulse field ablation solves the depth problem as well, right? So you get more continuous lesions and a little deeper. Is this true? And if so, does that actually improve the efficacy compared to HPSD by that much? Because if it doesn't, and that's the perfect lesion, then it is definitely something else, some other mechanism and some other approach.
Yes, very good question. I'm not sure I can answer that because I don't have so much data on that. But the idea of PFA, and I think Guido will tell you more about this because he knows more about this than I do. But certainly, the idea of PFA is the tissue selectivity, and that we get transmural lesions without the risk of affecting additional tissue. But to me, so this is one of my great questions, is if we can indeed prove that PFA is correlated also with less early recurrences, because this is what I would expect. If we say we find less inflammation and we don't find tissue necrosis or only apoptosis, we will also have less early recurrences, and then maybe also less late recurrences. This is speculative. We don't have the data yet, and I'm hoping in this 1 year that I'll be able to get a bit nearer to the truth. But yes, Guido, maybe you want to.
I will interject that very briefly. With the current state of catheter design and energy delivery with pulse field ablation, we can easily get to a depth of a little bit more than, I would say, 5-6 millimeters, which is more than enough to ablate the structures of the atrium. At least when we're talking about PVIs, of course. What we don't know about PFA, of course, is what is the effect of the heterogeneity of the tissue, whether this might create a barrier to the electric field. The great advantage of radiofrequency ablation is that, as you saw in the first slides, the biophysics of the problem is it's quite tunable. If you apply radiofrequency ablation for radiofrequency energy for a short time, basically your effect is to transfer to hit your tissue and the contact with the electrode by Joule heating. And then this teardrop shape is given by the diffusion of the heat from the site of the contact away into the tissue. So this is great to create very deep lesion, for example, in the ventricle, even, or when you want to, for example, ablate subendocardial substrates. It's not completely effective when you want to reach epicardial foci. This is something that we don't have for PFA right now. Like Miruna was saying, the great advantage of PFA is the tissue selectivity. That the muscle is the tissue the most affected by PFA. For now, the depth that we can reach with PFA is comparable to what we would like to have in the atrium. So we are expecting more contiguous lesions. We are expecting transmural lesions. What we don't master right now, and our clinicians that work with PFA might confirm it to you much better than I do. What we don't master right now is how to measure that PFA has done its job. Because you can have myocardial stunning, you can have a loss of signals, but it's just a reversible phenomenon, and this is like edema, basically. and it's edema is reabsorbed, then you have PV reconnection. With PFA, you might have the same. You might see everything isolated. You go back 15 minutes later, and there is a reconnection. So high power short duration has one job: to have shallow, wider lesions that can spare the adjacent structures of the thin wall of the atrium. PFA aims to ablate only the myocardium, and by doing that, they achieve the same say trade-off. They want to be super efficient with the highest possible safety. So Jason, I don't know if I answered your question. The biophysics is very different, and they try to do the same. They try to be as efficient as possible with as less damage as possible.
Yeah, all of that makes sense. I think it's really interesting. And I think it all goes back to me. The question I always ask, even in modeling, is it the continuity of the lesion? Is it the depth of the lesion? Like with respect to the specific arrhythmia, like all these mechanisms and stuff is, even if you have the perfect lesion, no matter what method you use based on safety or whatever, it may just be that it's not having a perfect lesion, it's having the best placed lesion or something like this. So this is just where I'm going with, and I think the biophysics is different, and I think that's a really cool approach, and I think PFA has a really promising future. But this seems to be a very good alternative with just the radio frequency ablation. So you have two different tools in your book to do whatever. So it depends on probably where you're ablating as well for other regions outside of PV. But no, that's very, very, very cool. Thank you a lot.
If you see some of the, like, there aren't many commercial systems for PFA, but the Affera system, for example, you can find it in the preclinical and clinical literature a lot. It's kind of harnessing the flexibility of RF ablation and the efficacy of PFA. So the inventors of the Affera system, they have created a catheter that can deliver both, so that the operator feels free to, for example, if they have to ablate the cavotary isthmus, to use RF. If they want to do a circular lesion, to use electroporation, so PFA.
Still, the standard response of a failure to reach 100% of freedom of atrial arrhythmias.
Yes, this is actually. Thank you for coming back to this. Even if you see the latest papers from, I don't think it's the latest now. It's the one that Pierre Jason, the other members from Prague, are now in the BDIF. Vivek Reddy, they published the results of the PEFCAT 1, 2, and the Impulse trial. We still have this damn number of 85% of freedom after 1 year. So, and this was the
this is very frustrating. I understand, yes. But the standard response is to make our lesions deeper, more contiguous, or simply more. But maybe that is not the right response, because we know that in patients in whom there is reconnection, the ablation is still successful on the long term. So maybe it's not entirely necessary to ablate the entire circumference of the pulmonary vein, but maybe you have to look to other mechanisms, for instance, like stretch, as Lisa Gottlieb has shown. It's just an idea, but maybe our standard response is not sufficient to make deeper lesions, or more contiguous lesions.
Right.
Sorry for the critical note.
I think they are welcome here.
The fact that the guest name RF has not argued with you, so I think it's a good sign.
I don't know who that is.
Radio frequency ablation.
Okay, I think we are right on time. So if there aren't any questions, I would leave to you, Ruben, to give us our closing remarks for now. I would just like to put like as a joke as usual, like this time, even if it was my turn to moderate, you were not tortured with a basic science paper, but don't just relax yourself, because Miruna is working also on pathophysiology of atrial fibrillation. So soon she might present something about basic science.
Yeah. Well, thank you, Guido and Miruna. It was a very nice presentation and a very interesting journal club. Thank you for that.